Hi, I'm Sarah Mitchell Chen,
And I'm Dr. Joy Fleischer.
and we want to welcome you to Rush Recap, another in our series of short educational videos to help address some of the most frequently asked questions we hear from patients, families, and care partners here in the clinic. This project is made possible by a grant from the Parkinson's Foundation to help integrate primary palliative care into your day-to-day clinic visits. And so check out other videos that help explain a little bit more about what palliative care is and the philosophy. But we want to welcome you to today's talk. And Dr. Fleischer, I'm wondering if you can help explain what is what is a DNR, or what is like default code status? I know sometimes our patients come in with questions about what that means for them.
It's a really great and it's a really important question. So let's kind of talk about where this comes from, which is um, for everyone at some point their heart stops, right? And we hope that that is a long, long, long time from now. Okay. But if you are in the hospital and for some reason your heart stops, if you are found down and you're lucky enough that a good Samaritan is walking by you and your heart stops, the default in the hospital is always to do everything we can to try to get your heart to start back again. So essentially, if someone's heart has stopped, they have died, and we are trying to get their heart started back again to see if we can bring them back. Right. And so the default in the hospital, if your heart stops for any reason, and we don't have anything that says otherwise on file, a whole team will rush in, a code will be called, which means alarm bells go off in the hospital, a team of doctors and nurses and respiratory therapists, and a whole team of people come in, and they will use chest compressions to try to get your heart started back again. This means pushing really, really hard on the chest and sometimes even breaking ribs. This means trying to get air into your lungs so that the heart can pump that around, which could be from a mask with a bag attached and pumping oxygen. It could be by putting a tube down your throat or intubation to try to get oxygen into the lungs in a safe way. It could be administering medications to try to get the heart jump started again. It could be shocks. So if you've seen a defibrillator, sometimes they're out in public places, but sometimes you see them frequently on TV, as people will get shocked and sort of, snap back, their eyes jump open and they snap back to life. That is not how real life tends to work. But all of that is part of the default. What anyone in the hospital will do to try to get a person's heart restarted to regain a pulse if they have lost that.
Dr. Fleischer, does it matter the age of the patient?
The default, the assumption is always that we will do everything to keep that person alive unless they have told us otherwise or that something else is more important to them. So all of us obviously want to live as long as we can and have the best life that we can. So why would you say anything otherwise than that? Well, so there's actually really, really fascinating research that says on TV, if you watched ER, if you watch Grey's Anatomy, right, lots of times people have some catastrophic event and the team comes in and they do chest compressions and they shock the person and poof, they're back and they walk out of the hospital. And we wish that that were the case, but unfortunately, that is kind of a medical fantasy. So for a lot of people, despite doing all of those things, we may never be able to get their heart restarted and to get a pulse back. So it's a lot of injury to that person's body, in the last moments of life that aren't serving a purpose, that aren't helping to bring that person back. Or we may do all of these things and be able to get a pulse back. The person may, be intubated, so have a machine that is breathing for them and keeping them alive, and they may never be able to wake up again. They may never be able to come off of that breathing machine again. And for some people, if quantity of life, no matter what that looks like, is the goal, then that may be acceptable. But for other people, they may say, I wouldn't want my family to see me like that. I wouldn't want to be kept alive by machines if there's no meaningful chance that I could recover. And sometimes in an emergency, the doctors don't know what the chance of recovery will look like, right? But for other people, if we know that a person has poor health or has medical conditions that would mean that if they were intubated, if they needed to be on a breathing machine, it would be very hard, if not impossible, for them to ever get off of that. We may know things like that ahead of any crisis and be able to say, if you or if your loved one were to have a really severe pneumonia, you might do okay. You might need some oxygen, right? And you might do okay with that. But if it were to be really severe and you needed to go to the intensive care unit or ICU, and if they couldn't help you enough just with regular oxygen, if they were to need to put a tube down your throat, we are concerned that that tube might never be able to come out. And is that something that you would be okay with and that you would want? And so what code status is a way for you as the individual, or if you're the healthcare power of attorney for your loved one, to say, yes, I want the default for me or for my loved one. No matter what happens, if my heart stops, I want you to do all the things, right? Or you might say, you know what? I want all the things up to a point, but if my heart were to stop, I don't want you to do everything to try to bring me back. If that means that you are, pounding on my chest, shocking my body, putting a tube down my throat, if there's very little chance of meaningful recovery. What I do want is you to do everything to make me comfortable. And so something that I think is a myth out there is if I say DNR or do not resuscitate, that means that the team is going to do nothing. So there's this false idea of full code, or the default is do everything, and the opposite is do nothing. And I hope that we can kind of change that understanding to full code means do everything to try to bring my heart back, to try to resuscitate me and get a pulse back. Do everything that medical care has to try to get those numbers and basic functions to come back, knowing that we may not be able to. Whereas do not attempt resuscitation means if my heart has stopped, do everything to make me comfortable. It is not, we're done, everyone steps away and leaves the room. That is not what happens. DNR means the person who has said, do not attempt to resuscitate me when my heart stops, whenever that is, says, I don't want all of those extra things being done. I want you to make me comfortable. So I think that's the difference. And there is, so sometimes, and Sarah mentioned in one of the earlier videos, that there's something called a MOLST or a POLST, which is a medical professional or provider or physician order for life-sustaining treatment. It's kind of a shorthand that one keeps at home and also gives copies to their healthcare providers. But it says at the top, this is kind of meant for if something happens, if there's a crisis and 911 is called to your house, right? The paramedics run in and they find the person in distress, or they find that the person doesn't have a pulse. They know actually to look for this brightly colored piece of paper that we hope that you will put on your refrigerator, because they actually are trained to look for it there. And at the top, the very first step is, if I do not have a pulse, do everything to try to bring that pulse back, or do not attempt resuscitation. Do everything to make me comfortable. So that's what DNR or DNAR, which is sort of the more appropriate term, do not attempt resuscitation, because even when we attempt it, we may not achieve resuscitation, right? And so that's often the top question on one of those pulsed forms is, when my heart stops, what do I want the emergency folks to do? And that is kind of a black or white. Do they come at me with everything to try to bring my heart back or not? So does that answer that question?
I think that does help clarify, and the recognition that even if we've come to a place where we do not want resuscitation attempted, we do want comfort.
Right.
And we want comfort care measures.
A DNR does not mean abandon me when I am in need, ever. So I think that's really important to know.
Well, we thank you so much for clarifying that for us. Please know that if questions come up for you as you watch these videos, please write them down, bring them to your next appointment with your provider, and they can help walk through some of this around when might it be, what would happen if I, from your provider perspective, if I were to get a serious pneumonia. They may be able to help give you a little more information. None of us have crystal balls, but with their medical training, they may be able to help give you some insight that could inform your decision about, would I want to change the advanced directives that I have created, or would I want to modify one or create a new one? So thank you so much for joining us today. Continue to review the various Rush recap videos and the other information available on the Rush Movement Disorder Patient Education page. And thank you so much. We appreciate your time.
Thanks.